Hi, welcome. My name is John Burgart. I'm the head of US marketing at Abbott Core Diagnostics. Today we're going to be talking about the value of US laboratories. I want everyone now to ask yourself a question. What's the biggest issue that labs face today? Now, I've gone around the country and probably talked to about 100 hospitals this year, and one of the largest things they bring up is staffing. The second one is capital investment, and the third is reimbursement. Today we're going to be talking about how you can formulate a strategy to address all three of these things in your system. They all center on one concept, and that is the value of the laboratory and what it brings to the system. If you don't have enough resources, if you're struggling to find those, we're going to uncover ways today that you might be able to address this in your systems. So let's ask another question. In your head, now just picture, is your lab considered a profit center or a cost center? Just in general, what do those words bring to your head? From a business standpoint, it's really defined as revenue centers are things that focus on top and bottom line revenue. Systems that have these revenue centers address additional capacity, you invest in volume and activity expansion, and things that look like that for the lab are outreach, population data warehouses, and diagnostic network design. Where do you put your labs in these larger systems, or if you're a smaller system, how do you address the flow of doctor testing? Now, for most hospitals in the US, even if they are seen as a revenue center or a hybrid between the two, most hospitals focus on cost center metrics. How do you reduce costs as far as possible? How do you maintain service levels at acceptable rates? Turnaround time is that minimum level of service that hospitals expect from their labs to be able to maintain. If they cut costs so far that they affect the turnaround time, then they look at the strategy of reinvestment, cost reduction, and other services that might be throttled. Most hospitals in the US operate as cost centers, and this is an important fact because the cost center strategy is to reduce until you hit kind of a stable state. Most hospitals in the US have cost reduction profiles of between 2.5% and 5%. That is completely normal for a cost center. Now, here's how it actually works. In 1960s, there was an advent of the diagnostic related grouping, the DRG, bundled payments. That's for inpatient. For outpatient, it's called APM. There's a lot of different models that go with this. However, in 2010, that actually got codified into law with the Affordable Care Act, ACA. What that means is that hospitals now saw revenue coming from doctor engagement in disease state identification. So once you have a DRG, let's say you have a cardiac arrest, an AMI, you now get about a $24,000 payment to treat that AMI, everything that goes into it. So in previous states, we had fee-for-service. Fee-for-service was pretty simple, right? If you used a tongue depressor, you paid for a tongue depressor. If you used a lab test, you paid for a lab test. Now all of that activity, the average of all those activities gets bundled into a DRG. What that has caused is a system of finance where they invest in more doctors. In fact, since 2010, doctor group purchasing, like actually buying the doctor group and bringing it into the hospital, has been one of the largest investments that hospitals have made outside of their EMR. What that means is that they're actually driving, based on their financial status, physicians into the organization. Now, there was a study done by G2 Consulting that actually showed that doctors coming into the system and not using the services cost the system approximately $100,000 per year per physician that doesn't use the internal services. Now, why is that? Let's wrap our mind around this for a second. This is one of the hardest things to uncover before we move into the larger strategy of improving our systems, and that is this. CMS, the Centers of Medicaid and Medicare Services in the United States, requires hospitals annually to report the breakout of the DRGs by department. And so what you see on the right-hand side of this screen is an actual hospital that has broken out all of their DRGs to show where money is actually made. In this particular hospital, drugs charged to patients, that's pharmacy, is the largest revenue center in that hospital. OR is second. Doctor care, and this is inpatient doctor and nurse care, is the third highest revenue center. Now, does that surprise anyone? Does that surprise you? That doctors aren't the top financial moneymakers in the system. And interestingly, in this particular system, the lab is number 4. The lab is in the top 5 of revenue makers in this particular system. We'll look at a very specific system later, and I'll show you how that breaks out. But this is what we need to recognize as an organization is, if this is true, and if we make revenue on a department, and let's say that your hospital decides to outsource any one of these departments, that third party that takes it is taking the revenue that you actually make. And if that revenue is hidden from your system, then it might be very unhealthy for your system's margin. And again, margin is defined by the difference between top-line revenue, that's what you bill and what you get, and what it costs to make that revenue. We'll show you that in a little bit on how that actually works. So let's focus on this kind of paradigm. If you particularly have a 5% cost reduction goal, and the hospital has a 5% growth goal, and laboratorians, if you've been looking at your lab tests this year, a lot of people have been reporting to me that they're growing between 5 and 10%. What does that do for your effective cost reduction? It means that the 5% growth that you need and the 5% decline that you need in costs means that your effective cost reduction has to be 10%. That's very difficult for systems to do, especially when 50% of their pricing or their costs are based on personnel. The rest are pretty much fixed costs based on the number of tests you do. And for a cost center, that's a very tenuous model because you're really focused on reducing, and the only place to put that is in people. And therefore, you kind of perpetuate this staffing problem. That's why a change in model is what's required. Because hospitals that do this, they must throttle services and staff, which for a revenue maker, if you're a revenue maker like we showed on the previous slide, that's massively unhealthy for you. Hospitals today run at somewhere between, after all things considered, somewhere between a -4 and +4% operating margin. Meaning that after you take out insurance and after you take out operating costs, most hospitals in the US run negative for the money that they make. Now, they have other investments, they have endowments, they have other things that come in a bucket that's called other income. And that other income, once it comes in, brings the margin right around 0. But the question is, are they investing in departments that grow their margin? The biggest thing that hospitals are talking about today in the senior leadership level are new lines of revenue. And it's critical that they understand where the revenue actually comes from. So let's look at Westview Hospital. Now, this is an actual hospital in the US that we have masked the name for, made a logo for, but this is real data. In this particular system, they have 2 hospitals, 1 physician group, 6 urgent care. So you might consider this to be a medium-small system, right? You have the gigantic ones in the US, but then you have these medium-small that are moderate hospitals. This hospital bills $3.6 billion annually. They have a negative $29 million net operating income. And what that means is that $3.6 billion, once you take away all of insurance, which usually takes away about 75% of that revenue, and then you take away operating costs, they actually run at a deficit. And that deficit means that they have a negative 8% operating margin. Now, if you're not familiar with finance, don't worry. At the end of this, there's going to be a QR code that you can link to get your own individual hospital's financial report. This is the data that your hospital sends to a third party, we mine it, and then we bring that back to you. So it's your hospital's data, and we'll show you what your lab revenue actually is. Team, you can see this for your system, and we can present this to your leadership the same, but instead of Westview, it will be insert your hospital here. What you see here is that the highest gross billing department is the OR. That's pretty typical. OR is on all the strategic committees. After COVID, everyone was trying to get patients back into the OR because that's where they see a lot of the revenue. They can see that because doctors are involved in it and the billing is pretty straightforward. But the next three in profitability line is lab is number 2, pharmacy is number 3, and ER is number 4. In fact, in this system, and this is pretty normal, the lab bills $500 million gross. After you take away the hospital's average insurance rate, this system bills $35.3 million at a 16% margin. Here's what that means. One, the lab is about 10 to 12% of all hospital billings. That's very typical in the US, and something that's very much not known by the C-suite. We have actually validated this data with multiple CFOs, and they started to look at this differently. They started to look at lab not as a cost center that needs to be reduced, but potentially something that requires investment to be a new line of revenue. So that $35.3 million at 16% margin, what that 16% margin means is that every dollar that the lab makes, it pulls up the hospital operating margin. It makes them more financially valuable. If you reduce or get rid of the lab, which a lot of systems are doing these days, they're selling it to a third party, which sometimes that makes sense. But for most hospitals in the US, it might not. That one-time payment might take away your second highest billing department. In this particular hospital, for every $1 in costs that they incur, they have $13 of gross revenue. They bill $13, and then they pull through about 2 of that. So again, if I had a business where I invested $1 and I pulled out 2, 100% invest in that. Same with this system. And you can see it if you look at the graph here, that you have to take in revenue and costs. Now, if you looked at the lab just in this graph and just on costs, they're going to look like something that you can cut. However, when you look at the revenue line, generally, everyone would agree that you should not reduce the lab. In fact, you want to look for ways to grow it. I'll give you one way to grow it right now. If your hospital has leakage, now leakage is defined as any physician in the system that the system actually has a paycheck for. So if a physician is owned by your hospital and they send out tests to a third party that you could do in your lab, those tests cost your system money. You pay that third party to do those tests, and you no longer get to bill the revenue. You don't get that payment back. So you have to give that third party the money to do that test. If you pull those back in, that's revenue that your system can use. We actually have a reference site in California, and in doing this activity, they brought in 1 million annually new tests into their system that they weren't running before that other doctor offices were. Here's how they did it. 1, we did a strategic workshop with them and identified this as an opportunity. 2, the head of labs there sent their staff out to different doctor offices as they went home in the evening, and they looked for drop boxes from third parties. If they saw those, they called the doctor the next day and asked what tests they were doing and tried to bring in the ones that they could do themselves. They continued to send out anything that they couldn't do or wouldn't do or didn't make sense because it was too small of a product. However, that brought in 1 million tests. And if you think to yourself, is that more testing? No, it's the same testing that doctors were doing originally, but now the internal lab does it, and they get the revenue from that at the higher margin. You can do this too. That's the kind of the lowest hanging fruit that any hospital that's listening to this right now can do. So here's how lab profitability works in a nutshell. So first you have the bill rate for your hospital. That bill rate is usually set fairly high. And the reason it's set fairly high is so that they can give insurance companies a reimbursement reduction on that in exchange for capturing that insurance company's clientele. So you give them a massive reduction of 70% on average, and they send their 1 million lives that are now in network in your system. Once you take that out, and then you take out the 10 to 20% of costs in the lab, then you're left with the total operating profit, which again is about 10 to 20%. And this is a well-studied number, team. Going back to the 1980s, lab profitability is actually something that's been massively studied, and we just don't communicate it because of the DRG system. If you look at those costs themselves, again, 50% is labor, 31% is supplies, 15% is reagent, and 4% is other. If your hospital is growing and doing more testing, where then do you have to cut? You either focus on doing less tests, which some hospitals have reported doing, or you have to cut people, or you don't pay your people a rate that means that you're going to have the staff that you need to run the tests that are there. One of the things that you can do as well is run an analysis of what the profitability is of the lab by the resources required to do that testing. My usual estimation is whatever the test costs, add about $1 for the staff and all the other things for that test, and then compare that to your reimbursement, and now you know the spread. Okay? That's what's important as you look at your lab as a business, team. So this is a guy named Stephen Ellop. And Stephen Ellop was the CEO of Nokia. Now he went to an annual review and once said, "We make great phones, team. We make great phones." In fact, I had a Nokia back in the day. I used to be a chemical engineer. And in Texas, I actually dropped my Nokia phone accidentally into a vat of very light acid. Pulled it out, dried it off, rinsed it off, did all the things, made a phone call the next day. That was the power of Nokia phones. They were great. About a year later, this is actually a picture of Stephen Ellop on his way out of Nokia. And he said, "We didn't do anything wrong, but somehow we lost." Because a year previously, he said, "We make great phones, team. We don't need calendars, we don't need pictures, we don't need movies, we don't need anything else on it but doing a great phone." And somehow they lost. Hospitals today are in the same boat. We're doing the same thing we've always done, but somehow we lost. And that's the power of not doing the models correctly. As you start to sell your services, you might get a one-time lump fund into the hospital, but you actually end up losing more money over time. And that means that you're stable for 2 or 3 years, but then you start to fall off relatively rapidly. That is a proven model in the US for hospitals. Those hospitals generally get bought, they don't go out of business, but they change ownership to someone that has figured out where the revenue comes from and goes. Think about it from a personnel standpoint. So, I'm someone that has their own primary care physician. My brother, who's 5 years younger than me, doesn't. He uses immediate care or urgent care for anything that he needs because he can get in immediately. That urgent care and that immediate care typically is not in the hospital system. It's secondary to it. That's where the market is going today, distributed care. A few years back, there was a company that said they could do a blood drop on a chip, and everyone invested in it. Now, that turned out to be a falsehood. We won't go into that whole story, but you're familiar with it. It showed that there was a market for distributed testing. How are your labs preparing and ready to go into the market and meet the customers where they want to be? In the US, there's a saying, especially in the Midwest where I'm from, that you need to skate to where the puck is going to be, not where it is. It's the same thing for lab strategy. And if you don't have that strategy today, don't worry. We're going to talk about how to build that in the future. Okay, this was an actual system that was offered $30 million for their lab. That lab, that was a one-time payment they were offered, that lab was actually worth about $84 million net a year. Let that sink in. But the hospital didn't see the lab as making revenue, and they nearly sold it. We were actually sitting and giving a presentation, one of the precursors to this, at that lab, and we were showing how much revenue they made, and they said, "But we don't make revenue. In fact, we're thinking about giving this to a third party." Well, actually, we showed the revenue. They brought us to the CFO. The CFO validated the revenue numbers, and they decided not to go with that third party. But then they had a $30 million gap that they had figured already into their finances. So they went to the lab and they said, how are we going to solve this $30 million problem? The lab said, oh no, the only thing we know how to do is cut costs. And that's 20% cut of our costs. That's a lot of money. We're going to have to cut all of our people. This is horrible for us. We've actually made it worse. And instead, what actually happened is we, again, had a conversation with them and said, no. Remember, you're a revenue center. You can grow by less than 5% and cover that same number over a 5-year span. And they took the strategies. They started to look at outreach into the market. They took in more testing from other hospitals that didn't have the resources to run a lab. And they actually started growing between 5 and 7% annually. That's the power of looking at labs differently. So again, when we look at the fiscal model, because there's 3 legs to this stool, I've spent the most time on the fiscal model because that's the one that needs the most change in hospitals today. It's the one that has the most misunderstanding about what the actual process is to improve it. And you have to change some of your models. Transfer cost accounting, as an example, if you change your password in the hospital and you have to pay another department $20 per changing that, that's transfer cost accounting. So if you do testing for the hospital and you know based on the CPT code what the approximate reimbursement is, that's your revenue. You have that. It's just not calculated in your financial systems. It can be. And some hospitals, about 5% in the US that I personally have visited, they do it that way. Okay, so again, if you are misaligned from the fiscal matters, that throttles your growth. You lessen the voice of the people who can fix the issues. If the lab is a top 5 financial powerhouse in your system, ask yourself this question: am I sitting at the table for the next 3 to 5 year strategy overviews? If you are, great. You can bring this in and actually create projects that are funded to increase your financial relevance for the system. Increase lines of revenue is how I would call it. But this is, again, only one leg of the stool. Once you get this right, yes, you can grow faster. Yes, you have optimized investment. Yes, your investment targets are now controlled by the top and bottom line. And there is some minor financial acumen that the lab will have to learn to run themselves as a business. But you already know half of that language, and that's cost controls. The other half is revenue growth. Now, again, I said there were 3 legs: financial, clinical, and operational. Let's talk about clinical. According to a CDC survey, 15% of the time, physicians are uncertain about test ordering. This is physician reported. So they're saying, I personally am uncertain about what test to order 15% of the time. Now, you might say to yourself, nah, oncologists, endocrinologists, those specialties know exactly what to order. And that's true. They have a very narrow focus on what they would order. But in med school, some med schools, about 15 to 20% approximately, don't have a lab course. You get that when you get your specialty training, but most doctors are not directly trained on labs. In fact, 8% of the time, physicians report that they are uncertain about interpreting test results, and 77% of physicians said that they would value additional interpretation from the lab to support diagnosis. Team, that's clinical value. Let me give you another example of how this works in your real system. Ask yourself and your department, whoever's watching this, ask them this question. Is it valuable when a patient is going from the ER to be admitted into the hospital? Is it valuable to know their diabetes status? Does that help turnaround time, length of stay, and other clinical measures of your doctors as they support this patient to become healthy? Most people would answer yes. Now, what's the best way to get at that? You might say to yourself, fasting glucose, but oftentimes in the ER, because it's an unplanned visit, that's not always the best way to do it. What about HbA1c? Could you do an HbA1c to uncover the diabetes status of a patient as they come in so that your doctors know that on admission? Yes, you can do it. It would fit as part of the DRG, and yes, it would take part of the profitability away from it. However, it would lead to further improvements in care, and that's lab driven. That's the clinical value of the lab and how much you can make things more efficient. Is it more efficient, as an example, to do an HbA1c test or 2 or 3 doctor visits to determine your diabetes status? An HbA1c will always be more efficient in those cases versus spending your very valuable doctor time diagnosing that separately. You have to be able to articulate that clinical value of the lab to ensure that you are seen as the strategic powerhouse that you are. If you don't do this, you have data misalignment, you have inefficient care, you delay diagnosis, you have data generators that aren't involved in the usage of the data itself. And that results in calls back to the lab. That results in, again, a lot of questions that you need to answer that could be answered already if it's part of the EMR design, if it's part of how clinical care is done. That's the power of the lab clinically. That's that second leg of the stool. The third leg is this, operational. And I'll tell you why I'm building 3 legs of the stool in a second. We all have heard the status that 70% of critical clinical decisions are based on diagnostics. And it's only 4% of the cost. Now, I really don't like that fact because it's kind of taken for granted. Yes, it means that 70% of critical clinical diagnostics are based on labs, but it's at only 4% of the cost. That cost line creates you as a cost center. It reinforces the fact that you cost money and that you're basically can be reduced as long as 70% of those decisions are still being able to be made and no one's complaining about it. The fact that really matters, and I want you to really internalize, is that 70 to 80% of all the data in the EMR is linked to lab systems. Let that sink in for a second. Your hospital invested a massive amount of money into the EMR to meet not only federal guidelines, but also to improve care. If your labs are 70 to 80% of all the data in there, is it important for your system to own that and for the hospital lab to help inform that as that EMR is being discovered, generated, and implemented? I'm familiar with a lot of hospitals that have done EMR transitions, that have looked at, bringing in value. EMR choice absolutely matters, but as you develop it, the lab's involvement in how that EMR works within the system is also massively important. And again, that is the operational value of the lab. If you don't do this right, you can delay profitability because IT is not aligned to bring in, say, outreach physician groups. One of the biggest complaints we have right now with some of the EMR systems is that it makes it a little bit difficult to bring in patients that aren't directly in your hospital and have a hospital-given patient ID number. It's hard to track care. This can also delay diagnosis and, again, investment delays or overspending based on lack of accurate capacity assessment. That means that as you look at your lab's capacity and as you look at the staff and as you look at the instruments that run it, do you have enough capacity to meet the revenue and cost obligations to your organization? We talked about finding and alleviating leakage earlier. Do that today. Send a letter to your physicians. If you want an example of what one of those letters looks like, again, follow the QR code at the end of this presentation and we'll help you see what other systems have done. If you invest in labs, and again, revenue is the key to this, but also clinical and operational. That trifecta of information allows hospitals to realistically invest in labs to grow them versus shrinking them. And it actually aligns your operations. This is a COO story here. Now, team, let me tell you why I'm talking about the 3 legs of the stool. So people make decisions for one of 3 reasons: heart, wallet, and watch. Watch is operational value. It's the time and energy it takes to do something. Heart is clinical value. That clinical value is the actual care of the patient. It's how a patient gets better. And wallet is the resources that it takes to do those activities. Now, your COO is going to be very much operational watch facing. Your CFO is going to be the finance, and your CMO, the Chief Medical Officer, is going to be the heart, the clinical. Where labs typically fall down in communicating their value is that they focus on one of those three legs and not the other two, regardless of who they're talking to. This message, this three-pronged approach, has proven successful when you go to people that look at all three. And I want you to think about yourselves, why you bought the car you bought. Everyone ask people around you why they bought the car they bought. If they bought a Lexus or a BMW or a Tesla, they're probably heart buyers. They buy because of how that makes them feel. That's the clinical aspect. If they bought it because it's a cheap price and that's what they needed, that's a wallet buyer. If they bought it like I do, I drive a Honda Pilot, if they drive it because it can carry a sheet of plywood in it and also the family, that's an operational buyer. Knowing who you're talking to and what they value is what is allowing hospitals to increase investment in those areas. If you have the chief medical officer, the COO, and the CFO bought off on your plan when it hits the CEO's desk, you are more likely to succeed. And that's what we're trying to help you uncover here as we talk about the value of the labs. Now, how does Abbott do this? And what's in it for Abbott? One, as you've noticed, I've not talked about any of our products as we went through this, and trust me, Abbott has amazing products. However, the first thing we need to get right is the operating model in your hospital that allows for investment and growth. We do that in what we call the Abbott Transformation System Alignment. It is a workshop of a few steps, 7 points actually, and the first one is Discover. Discover is where we sit down and actually go through what's the strengths, weaknesses of your system, where's your competition, where do you want to grow, what's the best lines of revenue for you to grow. When we've done this with systems, we've had the CMO and the lab director in the same room laughing and having fun with each other and uncovering the true value of the system and how it runs so that the lab can make suggestions as to how it can run better. It's been extremely fruitful and eye-opening for all participants within the meeting. Once we get done with Discover, we package back and say, hey, here's a great version of a beginning of a strategy. Here's the situational assessment of the land. Then we move to Envision. That Envision workshop actually is where we put the ideas on paper and evaluate them based on the organizational value it brings, clinically, operationally, or financially, and then the complexity of that process. If it's a high complexity, low value, you don't do it. If it's high value, low complexity, that is your 1 to 2 year strategy. If it's somewhere in the middle, that's your 3 to 5 year strategy. It's that straightforward, and it's a one-on-one workshop, moderated and actually a kind of a brainstorming session if you want to imagine it that way. The next 4 steps are specifically yours to take. It's where you design the engagement, you decide on how to get there, you execute that, and then you amplify it. The 7th step is to kind of redo this every year as part of your 3 to 5 year strategy continuance. Okay, now, I've talked about a lot of data, a lot of details, and I'll tell you that all of that only matters if this is the outcome. It's the people that we serve. It's the person that was identified as being pre-diabetic and able to take action in their lives to avoid diabetes and the costs and the pain that comes with. It's the person that comes out from COVID, from ventilation for the first time, and that we were super scared would never happen. Think about how important labs were during the COVID pandemic. Think about how that's changed since then to now. Have we returned to normal? Have you taken the opportunity to highlight the value of the lab in clinical diagnosis and treatment and care and held on to that? Most hospitals have slipped back. And that's okay, because the groundwork has already been laid to change the story in the future. If you want to do that, and if you want help on that journey, I want you to contact the team from Abbott to help you. Schedule this presentation for your leadership. It's about 30 to 45 minutes with questions, and we have good conversations and a lot of fun doing it. Okay, and so here you see the QR code to take the next steps with us. I'm really looking forward to that, team, and I hope you take us up on this. We don't use the data for anything other than sending you your own hospital's custom report and then starting a conversation. If you want to continue the conversation after that, and if you want to show this particular presentation with your hospital's data in it instead of the Westview system, I'm happy to do that. Let's define what success looks like with you and then take those next steps. Again, I hope you go to the QR code. If you can't go there, email the person that sent you this presentation and it will come back to me and we will still get you that report. Have a great day. I look forward to taking the next steps on this journey with you, and thank you for your time.